Hello, can you guys hear me? Hello?
Yes, hello.
Yeah. That's okay. So one of the common type of esophageal fistula is that your esophagus is going to end in a blind tube, and this portion of esophagus is going to be connected to your trachea, right? So what happens? What would be like the clinical features of this child when born? So what happens? For example, the food, if he eats, simply it cannot pass through the esophagus into the stomach. So simply he would be having like drooling of saliva. Okay, he would be having vomiting because this food is going to undergo antiperistalsis and ultimately you are going to see vomiting. Simply. Secondly, like as you know, the stomach is connected with the trachea. It means some air can enter into the stomach, so your stomach would be simply distended, showing that there is air inside the stomach. Simply, the gastric contents from the stomach can also leak back into your trachea, ultimately giving you a kind of pneumonia. If you guys remember, aspiration pneumonia. Okay, aspiration pneumonia. Right. Okay, so now let's discuss the second phase of development. So, can you tell me what the second stage of development?
Pseudoglandular.
Pseudoglandular.
Okay, perfect. So that is pseudo glandular. Okay. Okay. Can you guys tell me that which event or which structural events do happen in pseudo glandular stage?
Formation of the tubules.
Okay, you are going to see bronchiole, but till terminal bronchiole. Okay, the formation of bronchiole till terminal bronchiole. So, can you guys tell me that do the gaseous exchange take place in terminal bronchiole or not?
No.
So if the gaseous okay, still we have capillaries that are surrounding these terminal bronchioles, but you do not have the ability of terminal bronchioles in order to undergo the normal gaseous exchange of carbon dioxide and oxygen. So, for example, if a baby is born in 5 to 17 weeks, it means during his lung, the pseudoglandular event is taking place at that time. It means if he's born, he's incompatible with life. Incompatible with life. Why? Because for this child to be compatible with life, you need some kind of respiratory, like at least respiratory bronchioles, in order to undergo the normal respiration and exchange of gases, right? Okay, what's happening? Okay. Okay. So, for example, if this baby is born in 7 to 17 weeks, that is during pseudoglandular state, so you will be incompatible with life because terminal bronchiole do not have the ability for the gaseous exchange. Simply. So, the third phase of development, you got to understand, that is,
Canalicular.
okay, perfect. Can I do that? So, can you guys tell me that what are the structural perfect. So, okay, terminal bronchi, we were seeing them in pseudo. Okay, perfect. We are going to see respiratory bronchioles and also we are going to see alveolar duct. Okay, alveolar duct. So now you guys are going to, for example, if a child is born during canalicular phase of his lung stage, what do you think? Will he be compatible with life or not?
He's compatible.
Okay, so he can be compatible with life. Okay, so basically it happens at 16 to 25 weeks. Simple. Okay, so now you guys are going to tell me the other stage that is
Circular.
okay, secular. As the name indicates, you are going to form a kind of sacs that is terminal sac.
Alveolar.
Okay, perfect. So you are going to see alveolar ducts and terminal sacs that are alveoli. Okay, so once alveoli are formed, then you are going to see different septation in alveoli. So can you just tell me what's the significance of this septation inside alveoli? Okay, so the significance of septation in alveoli increase surface area. Okay, so as you know that gaseous exchange is also dependent upon surface area. So if we are increasing the septations or we are increasing the surface area, it means you have more surface for the gaseous exchange, and it would help you in order to have more concentration of oxygen inside your blood, right? Okay. So the last phase that is your alveolar. Okay, first of all, you are going to tell me the age or the time.
38 years. 28.
36 to 8 years. It means that after the birth, still you are going to see alveolar phase or the septation phase still continues. Okay. So in this phase, you are also going to see secondary septation. Like for example, if you have a single sac, this is your primary septation. This can be your secondary septation. So basically, the main idea is to increase the surface area as much as we can. So in order to have more area for this gaseous exchange, right? Okay. So now let's discuss some alveolar cell types. Okay. So you guys are going to tell me. Can you just tell me the cell types, alveolar cell types?
Type 1,
Type
pneumocytes. Type 2, pneumocytes.
Type 1 pneumocyte,
most common, most abundant.
type 2 most abundant, right?
Macrophage.
Type 1 is most abundant. Type 1 is most
Okay. Type 1 is most.
abundant.
Okay, that is 98%. Okay. So, can you guys tell me that what's the significance of these type 1 and cells?
Type 1 forms the thin lining of the alveoli.
Okay, so basically they form this thin lining. So that helps the alveolar, the oxygen and carbon dioxide exchange water. For example, if you have thin surface, it means it's very easy for these gases to pass through. Like it's very easy for the oxygen to come in and carbon dioxide to go out. And this concept can be seen whenever a person is having some pulmonary fibrosis or if he is laying down more of fibrous tissues. So it means the thickness of this membrane can be increased, and as a result of that, what happens? We can be seeing like some kind of diffusion deficit. Okay, like the diffusion is going to be impaired simply. If you are laying down more fibrous tissue, or if you are taking simply the it do affect the diffusion, right? Okay. Can you guys tell me that what's the significance of type 2 pneumocyte?
Yes. Surfactant production. Surfactant production.
Okay, first of all,
Create type 1 and type 2, and also secretase surfactant.
okay, regeneration.
Yeah.
Okay, so it's going to produce surfactants. So can you guys tell me that what are surfactants basically?
It's an emulsionant substance. Lipopolysaccharide. Yes.
Okay, so it's a lipopolysaccharide. What's the function of surfactants?
To decrease the surface tension.
Okay, it's going to decrease the surface tension, so it would just avoid the collapse of alveoli simply. Okay, so okay, this is very important. The regeneration you are going to see an MCQs in you world. They'll be asking you that we have a patient. He had undergone some kind of pneumonia, and right 2 months after, like simply after the pneumonia, his lungs were completely normal. So, which cell types contribute in this in attaining this normal lungs simply? So, what would be that? That would be your type 2 pneumocyte because it have the ability of regeneration, right?
Yeah.
Okay. So you guys are going to tell me, for example, if you have a baby inside the fetus and I want to check his lung maturity, so what would I do for that?
Lecithin sphingomyelin ratio.
Okay, perfect. Lecithin and sphingomyelin ratio. So, if for example, what's the exact ratio which
More
can
than
this
or equal to 2.
More than 2, then it's normal.
okay, so more than 2 is you are going to see
Healthy baby.
mature or healthy lungs. Okay. So, for example, let me give you a scenario. You are going to see you world MCQs related to that. For example, if a baby is born via a C-section or cesarean section, okay. So, what happens to the level of surfactants and why? What's the reason behind that?
Decrease because the baby is bearing that stress response.
Okay. So the surfactants are going to be decreased. Why? Because you have less stress.
Less
Can you tell me the specific
glucocorticoids.
hormone? Can you just tell me the specific hormone that is related to formation of surfactants?
Cortisol, insulin.
Okay, perfect. Cortisol and insulin. So basically, the idea is that whenever like a lady have vaginal delivery, so she's under great stress, and you guys know cortisol is one of your stress hormone. So cortisol or the glucocorticoids basically increases the proliferation of your type 2 pneumocyte. It increases proliferation of type 2 pneumocytes and which helps in development of or formation of surfactants, right? So in your word, you can also see MCQs in such a way. For example, if a baby is born via a cesarean section, so which drug or which drug should I give him? Simply, that is your okay. Just tell me a synthetic drug like
Dexamethasone.
okay, yes. So it's dexamethasone, right? And betamethasone, right? So you're going to see an MCQs related to it. Okay, so can you just tell me that in cardiology we also studied some kind of cells that were known as heart failure cells, right? Hemosiderin-laden macrophages. Perfect. Whenever that are hemosiderin-laden macrophages. So it means inside your alveoli, you are also going to see alveolar macrophages, right? And the significance of alveolar macrophages we will be discussing in like a condition. For example, if you have alpha 1 antitrypsin deficiency, okay? If you guys remember, that is, we'll be discussing that, okay? Emphysema. Okay. So now let's discuss another topic okay, that is obstructive sleep apnea. You are going to see a ton of MCQs in your board, okay? So can you just tell me that what is obstructive sleep apnea? First of all, you guys just tell me the presentation. How would a patient present with obstructive sleep apnea? The most high yield presentation. Obese. Okay, he can be obese, right? Okay. Daytime sleepiness. Remember? Hello?
Yeah.
Yeah.
Okay.
Loud snoring.
Daytime sleepiness. Why? Because of this obstruction, he keeps on waking up during nights, okay, and he's unaware of that. So he cannot have complete rest simply. So in daytime, he'll be complaining of daytime sleepiness simply. Secondly, snoring. If you are obstructing the upper airways, it means you are going to see like snoring, okay? Okay. So can you just tell me like what causes the obstructive sleep apnea and what could be some of reasons that contribute to development of obstructive sleep apnea?
Excess parapharyngeal tissue.
Okay, so you guys mean that there could be some anatomical causes or some neuromuscular causes. Yeah. For example, if we have, as the doctor have said, if we have like anatomical deficits in which you are going to see obstruction, okay, like the pharynx or the upper respiratory tract just obstructs. So as a result of that, what happens? Okay, can you guys tell me that? Okay, so let's go. Okay, so for example, if you have obstruction, so what happens to the level of oxygen in your lungs?
Decrease.
And increase
Okay.
carbon dioxide.
Okay, and increase carbon dioxide. Okay, so if the level of oxygen decrease, what do you think, guys, will happen to the pulmonary vasculature? Will it vasoconstrict or vasodilate?
Vasoconstriction happens.
Okay, vasoconstriction. Perfect. So, for example, if you are seeing vasoconstriction, so what do you think will happen to the pulmonary artery resistance? What will happen to resistance?
Freezes.
Okay, resistance is going to be increased. So, if we have increased pulmonary artery resistance, so can this lead to right-sided heart failure?
Yes.
Yeah.
Okay, perfect. So, it will lead to right-sided heart failure. Okay, whenever we have increase in pulmonary artery resistance, which lead to right-sided heart failure, what's that condition?
Pulmonary. Or pulmonary.
Pulmonary, okay. Okay, so there could be some anatomical causes and there could also be some neuromuscular causes, okay? So neuromuscular causes, for example, if the muscles that dilates your upper airway just weakened, okay? So it can also like simply obstruct your upper airway and as a result of that, you can see obstructive sleep apnea in this kind of individual. Simply, okay, so what approach could be used? For example, if a person is having some neuromuscular kind of reason for obstructive sleep apnea.
Stimulation of hypoglossal nerve.
Okay, perfect. If we stimulate hypoglossal nerve, so what would happen?
The tongues move forward in interposed diameter increases.
Okay, perfect. So the tongue is going to be like to move forward, and as a result of that, what happens? You are going to see increase in anterior-posterior diameter, and it can somehow correct this obstruction, right? Okay. So it was all about obstructive sleep apnea. So guys, you must know the presenting features. Like you'll be having an obese guy. You will be having some daytime sleepness, and it basically in the U world scenario, they will be giving you that heart. Why basically you do like complains that at night he snores a lot. Okay, so it indicates towards obstruction. Okay, so now guys, you guys are going to tell me what is chylothorax.
Lymph accumulations in pleural space.
Okay, perfect. So, for example, if it's basically seen during certain kind of surgery, for example, neck surgery, or for example, if we are removing some lymph nodes. So, like during neck surgery and removal of lymph node, so the thoracic duct can be injured. Okay, and once the thoracic duct is injured, simply it can just leak out the lymph. Okay, in the thoracic cavity, and simply you can see accumulation of lymph inside the pleural space. Okay, so this condition will basically be called as chylothorax, right? Okay.
Yes.
Now you guys are going to tell me, for example, if I am undergoing the thoracocentesis, okay, thoracocentesis. Okay, so I have some specific locations where I'm going to inject the like needle, and I'm going to just draw out the pleural fluid and just examine that. Okay, so you guys are going to tell me what's that best location. First of all, you guys are going to tell me mid clavicular.
Between 6 and 8 ribs.
Okay, perfect. So between 6 and 8 rib, basically you can like take out the pleural fluid via needle, and you can just examine, right? Okay, so can you just tell me at mid axillary line?
8 and 10.
Okay, so it's basically 8 and 10. Simply 6, 8, 8, 10, and 10, 12. 10, 12 where?
Paravertebral.
Okay, perfect. Paravertebral line. So you guys must remember this location. Okay, so you have one of your UWorld MCQs. They will be telling you, for example, if a person is having a thoracocentesis, and we are just using this location between 8 and 10. Okay, so which anatomical structure is more prone to injury?
Liver.
Right.
Okay, perfect. So liver is prone to injury with it. Okay. So okay. So guys, can you tell me, for example, for example, if a person aspirates, let's suppose his gastric content. So which side of the lung is like it's more likely to move into that lung? Right lung or left lung?
Right.
Why your right lung?
Because a more vertical path of the bronchus, right main
Okay.
bronchus.
Okay, so you mean to say it's like wider and due to the angle? Okay. So can you, for example, if this person is, for example, if this person is standing, so what do you think? Would these fluid go? Which lobe of your lung?
Lower lobe. Lower lobe.
Okay, perfect. It's going to move into lower lobe. Why? Because he's standing, the gravity is going to pull off all of those fluid content into the lower lobe. For example, if this person is in supine position, one of your lower left, what do you think?
Inferior part of the lower lobe or posterior
Superior
part
part?
of the superior lobe.
Okay. Okay, posterior part of superior lobe and
Superior
okay,
part of
Superior part of inferior lobe.
posterior part of superior lobe. Like it does make sense. For example, if a person is laying, so for example, if these are his lungs, he aspirates. So this part you're going to see accumulation of these fluids or gastric content somewhere here. So it would be posterior part of superior lobe and what?
Superior part of the lower lobe.
Superior part of lower lobe. Okay, perfect. So this is one of your newer MCQs that are going to touch on that. Okay. So now you guys are going to tell me perfusion to brain. It's mostly dependent upon one of you know thing.
Carbon dioxide.
Perfect. It's carbon dioxide. So can you just tell me, for example, if I'm increasing the concentration of carbon dioxide is increased. What happens to the perfusion of brain? Would it increase or
Increase
decrease?
because vasodilation happens.
Increase.
Perfect. Okay, increased. And what's the mechanism, Dr. Zainab, you were just telling?
Cerebral vasodilation because of carbon dioxide.
Okay, it causes cerebral vasodilation. Okay,
That is pushing reflex. That is
it's pushing
pushing
reflex.
reflex. Is that the one?
What do you guys think? Is it pushing reflex?
Ah, no. It's cerebral hypertension.
Yes. Okay, so for example, let me give you a scenario. For example, if a person is having cerebral edema, okay, and if this person came to me, so what should I do using this concept? Hyperventilate him or hypoventilate? Guys,
Hyperventilate.
okay, hyperventilate him, right?
Yes.
No,
Yeah,
hyperventilate.
Hyperventilated.
Okay, you are saying hypoventilated.
Hyper.
Okay, those who are saying hypoventilate the ventilation, come in front.
Yeah, hyperventilation.
I think it's hyperventilation, but I still don't know why.
I think like you need to if there's edema, we need to like
Carbon dioxide that it dictates the vasodilations of the cerebrum.
Okay, so those who are saying hypoventilation, okay, so let's interpret what's happening. If I am hypoventilating, it means
Vasoconstriction.
I am staying more of carbon dioxide inside my blood. So if I have more carbon dioxide, so what will happen to cerebral vasodilation as we have already
That increases.
increase vasodilation.
That worsen the edema.
so it would worsen the edema, right?
Yeah.
So we need hyperventilation. We need hyperventilation for that in order to blow out more of carbon dioxide, and as a result of that, we will be seeing cerebral vasoconstriction, which would help us with this cerebral edema, right? Okay. So, for example, if a person is having panic attack, okay. So, what do you think will happen? Hyperventilation or hypoventilation?
Hyperventilation.
Hyperventilation.
He would hyperventilate. If he is hyperventilating, it means you are blowing off more of carbon dioxide, right?
Yeah.
If you are blowing more of carbon dioxide, so guys, what do you think will happen to the cerebral perfusion?
Decrease. Decrease.
If we have decreased cerebral perfusion, what would be the outcomes then?
Nausea, dizziness.
Okay, you will be seeing dizziness. Okay, syncope, right? Okay, blurred vision. Okay. So, okay, now let's discuss another concept which we have already done in detail, that is pulmonary hypoplasia. Pulmonary hypoplasia. So, can you guys tell me some of the causes of pulmonary hypoplasia? The one which we discussed in.
Oligohydramnion.
Okay, perfect. Oligohydramnion. That is Potter sequence, right? So, what do happen, and what's the main idea behind Potter sequence?
Functioning kidney.
Okay, so you have less of amniotic fluid, and as a result of that, simply your lungs cannot stretch out and just be made in a proper way. Okay, so you also have another condition which we have discussed. Remember, guys, that is diaphragmatic hernia.
Yes.
Okay, so what basically happens in diaphragmatic hernia? For example, these are your lungs. Okay, and this is your diaphragm. So basically, all the okay. So for example, if we have hernia here, sorry. So it means all of the content from the abdomen is going to come here into the thorax, and it would just simply compress the lungs. So if you have external compression over the lungs, it means they won't develop well. Okay. Okay. In cardiovascular system, we have discussed a condition. If you guys remember, persistence pulmonary. Guys,
Doctors, arteries.
okay, associated with pulmonary hypoplasia, we have a condition that is persistent pulmonary hypertension. Okay. So, for example, if a person is having uh, hypoplastic lungs, so it means that the blood vessels inside the lungs can't form well. If the blood vessels aren't forming well, so what do you think will be happening to the resistance?
Increases
Okay, if we have increased resistance again, what's the effect on heart?
heart failure.
Okay, perfect. That is called pulmonary. So you can guys, you can just relate it with one another like that. Okay. Okay. So let's discuss pulmonary embolism. Okay. Okay. So can you guys just tell me what's pulmonary embolism? Hello.
Formation of emboli in the pulmonary artery.
Okay. Okay. And this emboli basically comes from which location most likely?
Lower extremity.
Lower extremity. Okay. So then it's going to travel into your heart. Ultimately, it's going to travel into your right atrium, right ventricle, pulmonary artery, and it's going to block some of branches of your pulmonary artery, giving you pulmonary embolism. So can you just tell me what would be the presenting features of a of an individual having pulmonary embolism?
Tachypnea.
Ismia,
You could be having tachypnea. Okay. Then
hypercapnia,
okay, hypercapnia. Okay. So can you just tell me that what's the effect? For example, if I this is my blood vessel, right, and this is my alveoli, right? For example, if this emboli came and it obstruct this blood vessel, simply, okay. So if I'm having no perfusion, okay, as it is blocking it, and I'm having ventilation. So what's this basically called? Ventilation without perfusion.
ventilation perfusion mismatch,
Okay,
That's
it's PQ mismatch simply. And we also, okay, what happens in trachea? You have ventilation but no perfusion.
That's a dead space.
dead space,
Perfect. It would just form a dead space, right? Okay. So, okay, so now let's discuss a condition that is neonatal respiratory distress syndrome. The last topic for today, neonatal respiratory distress syndrome. So can you guys just tell me what happens in neonatal respiratory distress syndrome?
Decreased
decreasing
surfactant.
surfactant,
Okay, so for example, if we have decreased surfactants or increased surface tension, right?
yes,
Can you guys just tell me some of the risk factor?
Prematurity.
Okay, for example, if we have prematurity, it means the the type 2 cells aren't matured enough in order to give you surfactant. So it can lead to neonatal respiratory distress syndrome. Other risk factor, what we
gestational
have
diabetes,
Diabetes.
gestational diabetes,
diabetes. Okay, one condition which you already discussed.
C-section.
This section.
Okay, C-section. Delivery. Okay, and what would be the treatment option which we have already discussed?
glucocorticoids, beta-methason,
Okay, glucocorticoids. One of you were MCQ. Okay, they are going to ask you. Okay. Okay, so for example, if we give these individual therapeutic supplementation of oxygen, So what do you think will happen as a result of that?
Retinopathy of prematurity.
Okay, why are we going to see retinopathy of prematurity?
Oxygen free radical damage.
Okay, oxygens are going to be converted into free radicals. Free radicals are going to damage some of your parts that are your eyes. Okay, so in order, for example, if they damage the retina, it's going to give you retinopathy of prematurity. Other complications.
Bronchopulmonary dysplasia.
Okay, bronchopulmonary dysplasia. Okay, so and we have already discussed how to screen individuals whether they have mature lungs or not. How to screen a baby. Okay, perfect. Lecithin to sphingomyelin ratio. You are going to see an MCQ related to lecithin to sphingomyelin ratio. You are going to see an MCQ in you. Okay, that is equal to or greater than 2. Basically indicates healthy lungs. Right. Okay. So this was all about today's lecture. Hope you guys enjoyed. So I'll be sharing the slides with you guys in the group. Okay. So thank you guys. Have a nice
Thank
day,
you.
guys.
Bye. Have a nice day.
Thank you, doctor.
Thank you, Doc.